Morning, Brain Turns. My name is Andrew Wong, and I am an acute care nurse practitioner at Lenox Hill Hospital. And I have the honor to kind of talk to you guys a little bit about what I do, how I got to where I got to, and then also we're going to talk a little bit about point of care ultrasound. And I hope that it's a fulfilling talk. It's a short, kind of brief introduction to ultrasound. But more importantly, I think it's a great topic because it is something for all of you who are deciding to go into medicine. No matter what you do, it's going to be something that's really going to be integrated into your practice. And so I understand it is your last day of the summer and your last session of this. And so I want to thank you guys for giving me that honor. And so when I first talked to Anoop about this and to talk about some of the different things, with what we can present, we talked a little bit about presenting ultrasound, but one of the things she also wanted to talk about was kind of career progression and things like that. So I am one of the clinical impact nurse practitioners at Lenox Hill Hospital. I work with critical care medicine, so taking care of the critically ill at Lenox Hill, which is part of the Northwell Health System. And so how did I get here? And let me just make sure that all right, so how did I get here? I started off in my career basically at the age of 16 when I was in high school. I was offered the opportunity to take a certified first responder course. And in New York State, a certified first responder is kind of like the most introductory level to emergency medical services. A lot of fire department, police officers kind of carry this role where you are basically trained in like CPR, basic first aid, and things like that. So I started off like that at 16. At 18, I became an emergency medical technician right before I graduated high school in 2000. And I started off college as an EMT. And one of the things that was a really big blessing to me was that I was involved in the local ambulance company or the collegiate ambulance company. And they really were kind of like my family in college. I really got the opportunity to learn from them, but more importantly, kind of build a lot of those, relationships and become friends with them. And, we were like one big family. I started off my career actually as a computer science major because I thought, computer science was cool at the time. And I wanted to learn how to code things and things like that. And I sat in my first computer science class, Computer Science 101. And as soon as I saw all the 0 and 1s with Boolean algebra, I was done. And I just was like, it just wasn't for me. But I continued to build on that, with the ambulance company and kind of, really get involved in practice as an EMT, really responding to 911 calls and things like that. And I really fell in love with doing that. And during that time, I also was, I held different leadership roles in there. I was one of the presidents at a time. I was one of the chief of operations. I became a field training officer, I was an advanced life support provider, and I was an educator. And that's kind of really important, I think, when you're trying to think about what you want to do with your career and where your career is going to go. I had gone into school thinking I was going to go into computer science, and then it changed into something completely different. And even though, at a young age, at the age of 18, I was doing all of these different things within the EMS company. It kind of still, when I tell my story, it goes in full circle. And so after I became an EMT and I was, part of the ambulance company, I kind of continued to explore what I wanted to do. And so I landed a job as a critical care technician at a level 1 trauma center. And this is a picture of T3, which is shock trauma 3. It actually is no longer there because obviously hospitals rebuild and they get larger and everything like that. What I loved about trauma 3 was the most acute bed that you could have at Stony Brook University Medical Center. We saw the sickest patients. We saw patients who were flown in from all different areas, major traumas. And what I loved about it was the acuity. Everything that we did had meaning. The stories that I can tell There were so many memories just amongst all of my colleagues working there, the things that we saw. And what I really will accredit Stony Brook to was that I learned a lot of everything that I know and what I do on a day-to-day basis from there. I was 18, 19 years old, and I was assisting with like thoracotomies. I was assisting with, blood mass transfusions. We were saving lives there. And one of the things that really stuck out to me was the nurses who worked in that trauma bay. And, I always credit two nurses that I worked with very closely, Juan Cerna and Mike Trauma. And they taught me so much about nursing and so much about the impact that nursing has. You didn't need anyone else to be there. They were the ones there, and they would fix things and, just report back to, whoever the team that was working with them. And so at a young age, I learned a lot in that trauma bay, and I really, really enjoyed doing that. And so I also spent some time becoming what's known as a cardiology assistant for a little bit. And during that time, I was taught how to read EKGs and, got really good at that. And then the next step was obviously to decide what I was going to do. And, I toyed with going to medical school. I toyed with all these different options. I didn't know what a nurse practitioner was at the time because there really weren't a lot of nurse practitioners that I worked with. But I did know a lot of nurses. And one of the things that was really great about the nurses was that they were very proud of what they did. All of them became board certified. All of them really would have these meetings with the Emergency Nurses Association. And so they set a really good role model standard for me. And so I went to nursing school, and after nursing school, I knew that my heart was always going to be in emergency medicine and critical care. And I was kind of that stubborn nursing student after I graduated, and I knew I wanted to do emergency medicine. That was my passion. That's what I wanted. I got all of these offers to work in ICUs. One of the things when you're a student is that I always tell people that you're on a job interview, right? And so a lot of places really liked me and gave me these offers, but I knew my heart was always going to be in emergency medicine and critical care. And so what I did was I became a critical care trauma resuscitation nurse at University of Rochester Medical Center, which is a level 1 trauma center. And this picture over here of offloading patients on Mercy Flight is something that I always loved to do. It was just something that I thought was so cool that I was able to take care of a critically ill patient off a helicopter and then transfer them to, a trauma bay where we would take care of these patients. And then to the right is a photo of me and my team. So working with Joe Gervasi, who is another critical care trauma nurse. And then Regina, who is one of our ED technicians. And it was such a great team. 85% of my shifts were working in the trauma bay, taking care of the most sickest of the sickest, the people who came in for different traumas, coming in for heart failure, patients who need to be on mechanical ventilation. And I learned so much doing that. Hands-on practice is something that you really start to get in your career that is really, really helpful. And I, had so many other stories of crazy traumas to tell and, that type of experience. And then, so as I got older, and I always said that was like one of the best jobs I had in the world. As I got older, I decided my family started having some things. I'm originally from the New York City area, but we had a lot of personal family issues that I needed to move back and be that good son and take care of the parents. And so I landed at Lenox Hill Hospital in the emergency department. I was one of the staff nurses there at the time. And Lenox Hill is a very special place. You guys have probably heard so many things about Lenox Hill. It is a tertiary center with a community feeling. That's probably the best way I can describe it, because I've worked in a lot of academic tertiary centers, and we provide so many services to all these different things, but really it's like a family at Lenox Hill, and you can walk through the hallways and you'll see the people that all the time, and they're asking about you, how your family's doing, all of this different stuff. And so having worked EMS in New York City, I kind of knew that, all of the different locations, and I knew, where emergency nurses would be taken care of the most. And what drew me to Lenox Hill was the leadership there. And in a short time while I was there, I was actually offered the role of the emergency department nurse educator. And that was a little crazy to me because at the time I was like, there's no way I can be a nurse educator. What are you talking about? Like, I'm not smart enough to do that. It's not something that I can do. And I was taught a lot of different leadership things during that role. And I got offered the position and I was asked to, kind of step up and help to provide teaching. They were like, you're a good educator. And people believed in me when I didn't believe in myself. And so to the right is a photo of some of the fellows that I had. And one of the great things about that role was that I was the nurse educator for both Lenox Hill Hospital as well as Lenox Health Greenwich Village, which is a freestanding emergency department. And one of the great things about that role was I was developing nurses who were already, competent, strong nurses. And then I was also developing brand new graduate nurses. So like nurses who literally just graduated out of school. And I really learned a lot through that. And during that time, I was offered the opportunity to be part of Hofstra's nurse practitioner program. And I was in the inaugural class of the adult gero acute care nurse practitioner program. So what an adult gero acute care nurse practitioner is, nurse practitioners kind of, they do their training based on the different populations they take care of. So an adult gero acute care nurse practitioner typically takes care of an adult or older population within an acute care setting, meaning in a hospital, versus there's like family nurse practitioners who can take care of the whole entire spectrum of family outside of the hospital, like maybe in an office or anything like that. And so I became an adult gero acute care nurse practitioner. And then after I became a nurse practitioner, I developed the role that I'm currently in right now. And so the role that I am in right now is the role of a clinical impact nurse practitioner. And the best way for me to describe that to somebody who doesn't work in the hospital is I always tell them, I'm kind of a paramedic in the hospital. And so if you really go back and you think to the beginning of my story about where I started, I brought emergency medical services into the hospital. What I do on a day-to-day is I respond to rapid responses, strokes, codes, any clinical deterioration right away. And I help to provide services to provide that critical care at the bedside, anywhere from resuscitation to, maybe something as simple as, an evaluation by a critical care team. I also work closely with the medical intensive care unit, helping to take care of the patients, whether it's procedurally or whether it's, helping to offer guidance, working with the resident house staff. I help to train the resident house staff in doing different procedures and stuff like that. And then obviously ever since COVID started, I helped during COVID to help manage, a lot of the patients because our entire hospital was kind of taken over by the medical ICU. One of the things that I do now is I actually work 4 different jobs, and I don't work 4 different jobs because I have to. It's because I really enjoy what I do. So like I said, I work as a clinical impact nurse practitioner with the critical care medicine team. I also teach at Hofstra University on the graduate level for the nurse practitioners, and I am a professor of nursing at NYU as well for the undergraduate program. And because I've always missed EMS, and that was the roots of where I started, I do critical care transport for basically a few shifts a month to kind of ride along the ambulance and keep that going on. So the lessons learned from all of this is that life is incredibly short, and that is something that is so important. Working at critically ill patients' bedsides all the time, I can tell you how how incredibly short it is, and never to take anything for granted. You know, everything's a lesson. You know, when I first started college, I kind of thought I wanted to do one thing, and then it worked out to another thing. Even mentoring people as an educator, or even mentoring my friends over time, sometimes people were like, oh, I wanted to go to medical school, and then they learned about different career pathways and things like that. Or people who may have gone to nurse practitioner school or PA school, and they're like, oh, maybe I want to go back and become a physician. Or, you know, it's an interdisciplinary team. And, you know, always be open to learning new things. No matter what happens, always chase your passions. That's what's something that's really important. Don't sell yourself short. That was something that I think that, you know, I think about the times when I was asked to be an educator, and I kind of was like, well, I don't know. Even though I did so much teaching as an educator in EMS, I was like, I don't know, because I always thought like that's above where I'm going to be. But you know, you learned those things. And then my last thing is something that I tell everyone. And I think that the only way to practice safely, and no matter what you do, is to always know the why behind what you do. And so whenever I talk to like new nursing students or new medical students or whatever, and they're like, oh, what's your advice for that? And I would say, know why you're doing what you're doing. It's something as simple as that. And it could be that, you know, maybe for a nurse, it's like, oh, I'm going to start an IV. Why are you starting that IV? Is it because you need to give fluid to the patient? Is it because you need to draw labs? Because at the end of the day, one thing that we have to remember as a healthcare provider is that we're humans, and we need to practice humanism and be able to give that back. The last thing you want is for a patient to ask you why you're doing something, and you're like, I don't know. Because, you know, I always say I could train a monkey to do a million different things, right? But you need to be able to have that conversation. So that's a little story about how I started in my career. And so the next thing we're going to talk about is point of care ultrasound. Now, for most of you probably don't know what point of care ultrasound is. And the idea behind point of care ultrasound, and this talk isn't going to be, I'm not going to teach you how to do point of care ultrasound. And I'm not trying to sell you point of care ultrasound, but I will say that point of care ultrasound is something, if you're going to go into medicine, that you will see in your career, in your lifetime utilized. I utilize it every single day now. When I first started as an ED tech, I would say we utilized ultrasound maybe once or twice a week. It wasn't a big thing, and now it's really the mainstay a lot of what we do. And so what is point of care ultrasound? It's bringing ultrasound to the bedside of the patient rather than a patient going to a destination for the ultrasound. And the data collected helps to adjunct decision making. And so one picture you can see over here is, you can see like this stethoscope, which is very traditional, right? But it has an ultrasound probe on the other side of it. There's some people who are out there who say ultrasound is going to replace, you know, the stethoscope. And I don't fully believe that, because I think that there is so much that you can still do with really good assessment. Ultrasound just provides us data, and it provides data to help us make decisions, right? And you know, a lot of people in the ultrasound community always say that the reason we do an ultrasound is to answer our questions, and it provides us this fast way. There's a lot of different things. So over here, you can see this image over here where the ultrasound is very bulky. It is something, you know, this is kind of how ultrasound used to be. Like if you come in with abdominal pain and I need to check to make sure you don't have acute cholecystitis, meaning that, you know, your gallbladder's inflamed, I would send you for an ultrasound test, where an ultrasound tech or a registered RDMS, an ultrasound tech would be going ahead and checking, you know, your liver to see what's going on with your gallbladder. And that could take time, versus if I go and bring the ultrasound to you in the emergency department, I can look at it really right away. There's a lot of different devices out there nowadays that are handheld ultrasounds. You can connect it to your phone, like one of my favorite tools, Butterfly, not a sponsor, but Butterfly is my portable ultrasound, and I utilize it on my day-to-day basis when I respond to rapid responses and stuff like that. And it allows me to make diagnostic decisions very quickly. And so when we think about traditional ultrasound, and if I were to say ultrasound to a lay person, one of the things that's really common is people always think about like babies, right? Like, oh, you got an ultrasound from a baby to tell if it's a male or a female and things like that. And we do utilize it for that reason. You can utilize it for a lot of those things, but we utilize it for a lot of other things as well. So why do we utilize point-of-care ultrasound? Well, it's fast and allows us to perform diagnostic and therapeutic testing in a quick timing to prevent delay in care. And time is money, or time is also life, right? Imagine, back in the day when there was like a rollover car crash. If you had a rollover car crash, you needed to resuscitate the patient, stabilize the patient enough to go to CAT scan. In order for them to go to CAT scan, they need to have a heart monitor. They may need a lot of different monitors, pumps, and stuff like that. You go to CAT scan, which is, depending where you work, could be either right next door to wherever you're resuscitating this patient, or it could be down a long hallway somewhere. You got to move them onto the table, all of these things. And they ultimately will need to go to the operating room because they had blood in their belly. But if I had a point-of-care ultrasound, or I had something like my, handheld ultrasound, I can just go place a probe on the patient, and I can do something called a FAST exam, which is a focused abdominal sonography and trauma, excuse me, during the initial phase, and then quickly decide, hey, this patient doesn't need to go to the CAT scan, they need to go to the operating room, or they need to go to a lot of different things. It gives us valuable time. Other major diagnoses that ultrasound can really look at would be like something called a AAA, or abdominal aortic aneurysm, which is your abdominal aorta, which is your largest vessel in your body, could burst due to like different things like hypertension, maybe you developed an aneurysm, things like that. We talked about cholecystitis, pulmonary emboli, and DVT, and really allows us to diagnose and make decisions faster. It's cost-effective and minimally invasive, right? It allows practitioners easier access to data. Something to consider is, I work in New York City, right? So I work in a very urban environment. If I want a specific test, I can probably get that test. Versus if I was working somewhere maybe like in, I don't know, Alabama, where it's a lot more rural, that, I may be the only provider in a large territory cover, I may not be able to get those tests. So it allows us to, it's minimally invasive. A lot of places like urgent cares are utilizing a lot of ultrasound nowadays because it gives us answers, and not all places have access to high technology, right? So maybe an ultrasound probe that can cost, like $2,000 that can be thrown in your pocket is really great, versus, getting an ultrasound that you actually have to push around, which can cost like, anywhere between $30,000 to $50,000. Or if maybe you're working in like another country that doesn't have access to a lot of things, you have that utilization. Ultrasound utilizes sound waves. It uses something called the piezoelectric principle, and it allows us to kind of look at a lot of different things. It also provides us safety nets, right? So it prevents complications, allowing us to be more precise in our imaging. We utilize it a lot for procedures. So this ultrasound over here on the right-hand side, on the lower portion, you can see this is actually lung sliding. So you can actually see this is an ultrasound probe placed on the patient's chest. You can see these dark areas onto the right side. Let me just make sure that I can, sorry. Make sure, so over here, these dark shadows over here are shadows of the rib cage, and then you can actually see the pleura sliding back and forth as the patient's breathing. And it answers our questions, and it's a supplement for formulating diagnoses. So we can't just go ahead and say, I'm going to put a probe on my patient and I'm going to diagnose them with something, right? We can utilize it for certain things, like if I'm looking at someone's ejection fraction, or which is the amount of blood that your heart is able to pump out. We can utilize that for some stuff. But when we need to make clinical decisions, we need to utilize and have data. So suppose I had a patient whose blood pressure is low. I can't necessarily just say, oh, their blood pressure is low because, they don't have enough volume or anything like that. I would need to go ahead and put an ultrasound probe on there and couple that with the blood pressure is low, the skin is cool, they're showing signs of shock. Now I need to figure out what type of shock it is. And ultrasound allows us to utilize that technology to kind of see what it is. And the last part of why we utilize point of care ultrasound is it's easy. Okay, with perfect practice, we can provide safe, cost-effective care. And you have to practice. And initially, when you start utilizing ultrasound, you might think, oh, it looks really hard. I can't tell anything, right? Like I don't know what that black area is versus this, whitish looking area. But if you utilize the education that you have behind with you of, basic anatomy and physiology, and then utilize the ultrasound and see, it's, perfect practice. I always like to tell my patients whenever they're like, oh my God, what are you doing with that? I was like, we're just playing a video game. And that's literally, what it is. And I think for a lot of people who is probably the audience on here, you probably will be utilizing ultrasound sometime in your career. So I want, when I prepared this talk, one of the things that I thought about was, how can we show like what's normal and what's not normal? And so we'll use examples and maybe kind of look at cases. So we can say this is like a 17-year-old who was riding their bike and they fell forward over to their handlebar. So now they're complaining of abdominal pain. And, on the way to the hospital, they were complaining that every single bump hurt, right? And so a lot of times when you think about those things, if I have someone who just fell over the handlebars, it's a high mechanism of injury, and now they're complaining of this abdominal pain, normally you could say, okay, well, I need to get this patient ready for a CAT scan. And okay, well, by the time the nurse puts in the IV and I go ahead and now I say, okay, well, let me put the order in for it. The CT tech needs to go ahead and, get the order. It could be like half an hour to an hour before I can get this patient over to CAT scan. Versus if I go ahead and take an ultrasound probe, you can go ahead and look at this. This is the hepatorenal recess, and you can see this is normal over here on the left-hand side. So you have the liver and you have the kidney, and there really shouldn't be much space in between over here. Versus over here, if I went ahead and I put this on, and now I can see this dark area, right? And this dark area is blood or fluid, right? So dark in ultrasound is always blood or fluid. And so if I look over here, I can say, okay, well, this patient is bleeding where they're not supposed to be bleeding. And so I can diagnose hypovolemic shock right here. This is blood in the hepatorenal recess in the Morrison's pouch. And so now I can, instead of spending that half an hour, 45 minutes to get a CAT scan and that time for someone to read the CAT scan, I have a pretty definitive diagnosis if their blood pressure is low and they're tachycardic to go ahead and maybe give a call to our surgery colleagues and say, hey, I need, this patient needs to be evaluated sooner than later. So other questions that we have, like this patient, why is this patient's oxygenation low? And so I can say this is a 39-year-old male who has jumped and now all of a sudden he's complaining of some shortness of breath. And he has crepitus on that left-hand side. And we can say what crepitus is. Crepitus is basically air trapping underneath the skin. And so when you push on it, it's kind of like Rice Krispies. Their pulse oximetry is reading 89% when normal is like, 90 to 100. So I can go ahead and put a probe directly on the patient's chest. I'll take the probe right here and place it directly on this chest over here. And what you can see over here, again, on the left-hand side is normal lung. And it's actually this line over here sliding black. This is back and forth. This is pleura. And so it's sliding back and forth whenever the patient's taking a breath. Versus on this side over here on the right-hand side, you can see that pleural line, a patient's not having any lung sliding on that at all. And so there's concern there that their patient could have a pneumothorax, which is actually air outside of the normal lung space. And so this patient ultimately could either A, if they have a tension pneumothorax, need to be decompressed, meaning we stick a needle in there so that all of the trapped air can come out, or we would actually go ahead and place a chest tube in for long-term management of that until their lung is able to heal. And so again, quick things, right? Normally I can go ahead and say I need to go get a x-ray. The x-ray tech has to bring the x-ray machine over, shoot the x-ray, and etc. Versus if this patient all of a sudden was now in this obstructive shock, meaning their blood pressure is dropping and they're looking really, really bad, I can make that quick clinical decision really quickly. This is a video screen capture of looking at patients' inferior vena cavas. Okay, and so this would be like kind of like a cardiac echo. or cardiac ultrasound. So it's a 60-year-old who presents with complaints of nausea and vomiting. His brain's out, saying that he's been nauseous and vomiting, and diarrhea after a cruise, right? So again, in looking at this patient, things that you might want to think about is like hypovolemia, electrolyte imbalance, right? You can get all types of viruses on cruise. I think that's been very highlighted recently during the pandemic. And then now they come in with a blood pressure in the 80s and they're tachycardic in the 120s. And so their heart rate's high and their blood pressure's low. I need to say, what's going on? Are they compensating for something? And so I can go ahead and put an ultrasound probe and I can look at this inferior vena cava over here, and you can see that it looks pretty full, right? The inferior vena cava is one of the main blood vessels that go back to the heart. And this is the right atrium of the heart. So this is kind of where it dumps in. And you can see that it's pretty full. Versus over here, it's very collapsed, right? So now when I think about managing this patient, do I want to give them more volume, or do I want to start them on something called vasopressors? So if I were to say that both of these patients were hypotensive, meaning their blood pressure is low, this patient over here, I might want to give them vasopressors. I may want to go ahead and give them something that's going to give them squeeze to increase their systemic vascular resistance, to go ahead and bring their blood pressure up, versus this patient over here looks like they may be under resuscitated. Maybe they need more volume. And that's something, you know, that's debated in the literature, that some people utilize this a lot, but it's a good idea to kind of look and you can see really quickly. Looking at abdominal pain, one of the things I talked about was the abdominal aortic aneurysm, which is really a high incidence of mortality. It is, you know, basically a lot of times what happens is your abdominal aorta, like I said, is the main vessel that carries blood out of your heart to the rest of your body. And sometimes when you have like things like chronic hypertension, or if you have a lot of calcifications, if you think about your abdominal aorta kind of like a hose, if that hose is constantly under high pressure, a lot of times you can have weakening of a part of a hose. Or if you think about like, if you had like a swim tube or whatever, and you've been sitting on it for a long time, that wear and tear can actually make like a ballooning and can actually pop. So this could be like a 59-year-old female who comes in with abdominal pain, and she says that the pain began in the morning and she passed out 2 times and she feels like her insides are tearing apart, right? And so again, we can order the CAT scan, do all of these things, versus if I just put an ultrasound probe on there. On this CAT scan, you can see that there's actually blood, and then there's this aneurysm right over here, versus if I go ahead and I just put this on, you can see that this darkened area, remember I said dark is fluid, right? So there's increased fluid. We can probably say most likely is blood. And then you can actually see how there is an aneurysm right over here in the center lumen of that aorta. And so again, understanding obstructive shock, I could be concerned about, you know, what other things that I may need to look at. And does this mean that I need to make a call to the surgeons right away? It saves time, and it's really relatively easy to do. I just go ahead and place an ultrasound probe on there. Looking further, we can evaluate other things. So when we talk about shock and someone's blood pressure is low, other things we utilize ultrasound for is we can go ahead and do a bedside echo or bedside ultrasound of the heart. And so I can look at a lot of different things when it comes to the heart. So things that I can look at is I can look at the contractility, how well is the ventricle contracting? I can look and see, you know, are we actually having good cardiac output? And so you can see over here, you know, this is a normal heart right here, you know, and this is shows you that, you know, the heart is actually contracting very well. This mitral valve is kind of slapping against, you know, the side of the ventricle. This is the aorta outflow tract. So the cool thing about this is to know basic, you know, anatomy and physiology. So you can see over here, this is the left atrium, left ventricle. This is the mitral valve. It's slapping up over here. This is the aortic outflow tract, the aortic valve that goes out to the rest of the body. This is the right ventricle. Versus in this patient whose blood pressure is low, we can go ahead and see that the side of the ventricle really isn't contracting that much. And you can see that mitral valve is not slapping along the side as much as well. So this person has a depressed ejection fraction. And then you can actually also see that the blood is kind of backing up a little bit in the left atrium. So understanding normal anatomy and physiology coupling with these images is really important. So this could be like a 77-year-old male who had a post-cardiac arrest. They noted what's known as ST elevation MI, meaning that, they had ST elevations, and they're having a heart attack, and now they're hypotensive. So I can say, well, this patient's in cardiogenic shock. What things can I do to offer to provide better care for this patient? Looking at this patient over here, again, I can look and say, why is someone short of breath? So I use this example. I do rapid response every single day. One of the calls we get often is like shortness of breath, okay? And I can go and see an elderly patient who's now complaining of shortness of breath and see what's going on. So I can do 2 different ultrasounds and look and establish. So in this patient, we just showed the same image over here. You can see that, we have a depressed ejection fraction, probably not functioning so much. And then I couple it with the story. Well, the story is they came in, they were having some nausea and vomiting. And so we decided to give them some fluid. So he got 2 liters of fluid. Well, 2 liters of fluid in somebody whose heart is not working as well might prompt me to go and say, okay, well, I can go and listen to the lungs and I may hear some crackles, which is anabatitious breath sounds. I typically talk about fluid, but you can see the same over here. If I put an ultrasound probe directly onto my patient's chest, you can see over here that, I have the pleural line that's sliding back and forth, so that's normal. But then we have these comet tail lines, right? And these comet tail lines, also known as B lines, typically indicate some type of fluid, whether it's a consolidation, whether it is, fluid, extra pulmonary edema fluid, and then I can make decisions. So if I were to see this and I would say, oh, the patient's short of breath, I probably wouldn't want to give them any more fluid. And so making those decisions are really important. Or if I were to say that maybe the patient's blood pressure is low, our typical response is to give volume right away first. I may not want to give this patient volume because clearly I can see that they're fluid overloaded already, and maybe I need to think about something else to support their care. Further looking at other things, so again, looking at shortness of breath and looking at different shock states. So one thing that we always think about is we think about pulmonary emboli. And so this is a 29-year-old female who's on birth control. So listening to the story, they have increased risk of maybe blood clots, and then on top of that, they're a smoker, which puts them at increased risk of blood clots. And on top of that, just came back from a flight from China. So has been sitting down for a really long time and now complains of shortness of breath when she arrived back. And she did notice that her right side of her calf also was really sore throughout the trip. And so over here, I can look at my patient. This is a 4-chamber view of the heart. So I can place an ultrasound probe directly on the patient's chest. And you can see over here, this right side of the heart is much larger than the left side. And that tells me that maybe there's blood flow that's backing up, right? And so there's, no forward flow or not a normal forward flow. This is known as a McConnell sign. Basically, there's backing up, that right ventricle is completely dilated. And then I would go ahead and place the ultrasound in the patient's groin just to go ahead and look at their major lower vessels. And you can see over here, this is the artery. The artery is a high caliber vessel over here. And you can see that there's this high, thickened lumen over here. And then this is the femoral vein over here. So this is the femoral artery, femoral vein, and you can see there's something in the femoral vein, and a vein should typically collapse, right? Because there's nothing there, it's low pressure. And so if I compress, meaning that I push down, I should be able to compress the vein. And so with this one, you can see that it's not compressible. And so I can probably say that this patient has a deep vein thrombosis, right? And that can lead to maybe the deep vein thrombosis, part of that clot broke off and then now is wedged into the pulmonary vasculature. And now I may have to think about, acute PE in this patient. Other things we can look at, so let's say that this is a cancer patient and they're now presenting with shortness of breath, a history of breast cancer, she's complaining of some shortness of breath, and I listen to her heart and she has muffled breath sounds. Well, I can go ahead and take a quick view. So if I look at this 4-chamber view, you can see that this heart is over here, normal. But then when I look at this over here, you can see this heart is actually bouncing back and forth. And remember I said, dark areas on ultrasound are typically fluid, and you can see around the pouch, the pericardial sac, there is a lot of fluid, and that heart really isn't able to beat because of that fluid, right? It's basically like the heart is in a bag. This is known as chandelier sign. It's basically floating back and forth in this fluid, and then we would think about, maybe doing a pericardial centesis where we would actually remove the fluid out to get rid of that fluid. Typically, it could be blood or it could be serous in nature, or we would think about placing a drain in as well. Because this is called brain turns, I had to include that you can do transcranial Dopplers. It is not something I do in my regular day-to-day practice, but you do have the availability to do that. And so it provides rapid, non-invasive, real-time measures of cerebral vascular function. You can use it to measure flow velocity in the basal arteries of the brain to assess relative changes in flow. I do know that one of the neurointensivists, Dr. C, I believe you guys had a lecture with him maybe, or someone on his team. They utilize transcranial Dopplers in the neuro ICU. And again, it's simple, it's non-invasive. You put a probe right in the temporal area, and then you're able to visualize some of the basic things over there. Something that we utilize all the time ultrasound for is we utilize it for a lot of procedures, and it allows us to really be precise in what we do, right? So we talk a lot about, something that I do on a day-to-day basis is we place central lines all the time. And back in the day, we place central lines based on a lot of landmarks, right? So if I were to go in the femoral vein or femoral artery, or I'm looking in the right IJ or the left IJ or the subclavian, I utilize a lot of landmarks to kind of say, okay, this is where I should be going. And you would go in blind a lot. And that puts you at risk for a lot of different things. Maybe you're not going to hit the vessel appropriately, or maybe that, you're going to go give the patient a pneumothorax because you're sticking a needle directly towards the lung. And those risks have actually decreased a lot because I can visualize exactly where I need to be. And I can also visualize exactly where my needle is. So you can see over here, this is utilizing it for a right IJ ultrasound guided central line. And so this is a longitudinal view, and you can see over here, you can visualize the vessel that you need to go for, and then you can actually see the needle entering into the vessel over here. And so that's really great because, again, it allows us to have precision in what we do. Over here is what you can look at. You can do other things like a femoral nerve block if I need to go ahead and I have someone who's having pain, or maybe they have a dislocated knee and I need to go ahead and block off that femoral nerve this way that, I can put the knee back into place. You have the opportunity to do that, and you can see the needle actually going directly where you want it to go. Other things that you might utilize it for is like someone who may be having liver failure and they're not able to hold fluid where they need to have fluid held. Over here, you can see, this patient has a lot of ascites, so there's a lot of fluid outside of where it needs to be. Remember, dark areas in ultrasound typically represent fluid. And so what we can do is we can do what's known as a paracentesis. So basically what I do is I take the ultrasound, I place it on the belly where I think I see fluid, I look for pockets, and we can do that with the lung as well for pleural effusions. And once I find a pocket, I can use that as a landmark. So when I put the needle in, I can actually draw out fluid. And a lot of times if patients are, with large ascites, they really can't breathe because their intrathoracic space can't expand because they have all this fluid pushing their lungs up. And so it allows us to, be able to help them offer that relief. So ultrasound in the time of COVID. So I'm going to just pause this video really quickly over here. So in the time of COVID, COVID was, something that was very, important for us. It was a time where we were kind of running around, taking care of a lot of different patients, and they're all very sick, right? So this is a case of an elderly male with a history of diabetes, coronary artery disease after a cabbage, hypertension, admitted for COVID, was intubated with acute hypoxic respiratory failure. And he was in the hospital for a really long time. And I took care of him after he his course was complicated by a GI bleed. He had tonic-clonic movements, acute renal failure, and difficulty weaning. So we had started him on proning, which is actually laying on the belly. It allows the lungs to expand better. And he was paralyzed and sedated for vent synchrony, and allows you to make sure that you actually can be on the ventilator, you know, and that we want the ventilator to do everything for you so we can, you know, make sure that we're heading in the right direction. And so I got a phone call from the nurse. I got a call from the nurse, and the nurse was like, oh, his oxygen's dropping and his blood pressure is dropping. And I was like, okay. So you go in the room, we made some ventilator changes, we changed some of his blood pressure medicines, and it would come back up. But then, you know, a few minutes later, they would call me again. They're like, his blood pressure dropping again. I don't understand, you know, like, and I go over and I'm still trying to figure out what's going on. At one point, what I had to do was I had to unprone him, meaning we had to put him back onto his back or make him supine. And we did a quick ultrasound, and this is kind of what the ultrasound showed. Pulmonary, good lung sliding, no pneumothorax. Again, this isn't a patient that I can go take down to the CAT scanner, right? The CAT scanner is already overwhelmed because there's so much stuff going on. And he's also connected to, you know, 8 different drips. And oh, let me see if I can pull up this video again over here. And you can see right here, there is a mass right here in the right atrium, and there's a big clot in the right atrium. Now, I said, you know, we were putting these patients on blood thinning medications, but this patient also had a history of a GI bleed, so it was a delicate balance. And basically what happened was that mass was going forward, decreasing forward flow, decreasing the cardiac output, decreasing oxygenation. And then, so when I went up on the blood pressure medicine and went up on all of the ventilator settings, that mass would move back. And then so he magically got better again. And then it was moving back and forth. And so it was important to kind of be able to have that, to diagnose that really quickly, and then to treat him right away, which we gave the patient TPA. So as we're kind of closing this, one of the things that I thought about doing, and I didn't realize that, you know, that there's such a big audience, which is amazing. But like, you know, we wanted you guys to kind of practice and think about what you might do. So this is a scenario of a 35-year-old male who is strained driver and rollover crash. So again, high mechanism of injury, was being chased by police going at 65 miles an hour. There was a positive airbag deployment, prolonged extrication. The heart rate is fast, 110, blood pressure is 80/60, respiratory rate is 24, and his pulse oximetry is 89%. And you see what's known as a seatbelt sign across the abdomen and chest, which is right over here. And they said they feel like bone cracking in his pelvis, right, or that crepitus. And when they pull him out of the car, the EMT noted that only the right side of the chest seems to be rising. The team's working on putting on an airway and putting in IVs to draw blood. And so we do what's called an EFAST, which is an extended focus assessment and sonography and trauma, abdominal assessment and sonography and trauma. And you can see over here, so this is a picture of what we said, that there is no lung sliding over here. The heart looks normal, okay? Pelvis has a lot of fluid in it, right? Or this is the bladder, right? The bladder has a lot of fluid in it. And then you can see over here, he has blood in Morrison's pouch, right? So making decisions really quickly, it takes, you know, what, 5-10 minutes to do an EFAST exam utilizing the ultrasound probe. I can tell you that now the patient probably needs a chest tube, and this patient probably needs to go ahead and have the operating room called. And then I need to explore what's going on in that pelvis as well, and what's related to that low blood pressure and that high heart rate. And then these are just some references. This is my information here if you have any questions or anything like that. And that's that. Any questions about being a nurse practitioner or, I guess, ultrasound?
I'm going to open up the chat real quick if you want to stop screen sharing and take a look.
So I have, what's the difference in the role that you play versus a doc versus a PA, different duties and responsibilities? Sure. So one of the things that I think is really interesting, you know, back in the day, it was like very all doctors and you're a doctor, you know, working in medicine. And working in medicine now, it's really an interdisciplinary team. And I would say that if you crosswalk all of the different things that we do, it's very different in the sense that we all have our own specialties, but we do a lot of the same work. Meaning that like PAs, I believe they have to work under, you know, straight physician practice versus nurse practitioners. A lot of us work under independent practice depending on what state you live in. So there's those different types of things. So the roles are pretty, the roles, I would say we work amongst interdisciplinary teams. It depends on what different area you work in. How long did it take for you to adapt to stressful situations working in critical care? I would say I always found it so interesting. And the nice thing that I would say when I was an ED tech, I got to play in the trauma bay without all of the documentation and the other things. So I always said, when I became a nurse and I became a nurse practitioner, there's so much documentation in what you do and you really take ownership for it. But as a tech, I didn't have that. And so I learned all of those things. And how I adapted to those stressful situations is, I always tell people, especially when I used to train my fellows, I always tell them it's our job at the end of the day, right? There's no emergencies in the emergency room. There's no real emergencies in the hospital, because if there's an emergency in the hospital, we have to figure it out. And so that's really important. What is my average day like? So my average day, what I normally do, and it's different on all the different days, but I typically see ICU outliers. So these are patients who were seen by the ICU team who are deemed stable to stay on the floor. Sometimes, obviously if there's a rapid or code, I respond to that. The patients who do stay on the floor, I do evaluate them and make sure that, with that critical care eye, making sure that they don't continue to deteriorate. And then I do respond to all of these different things. Are there some moments you regret not becoming a doctor? I think that's a really common thought and common question that people ask all the time. And I would say that I don't regret not becoming a doctor. I have so much respect for doctors. I have so many friends who are doctors. I helped a lot of my friends become doctors. And I would say that, for me, it's all about lifestyle and it's all about, your ability to do, whatever. One thing that I have so much respect for a lot of the doctors is they're going through all of this residency training and everything, and they really give a lot of their life to it. I get to do a lot of the same things, but at the same time, I also have my schedule of, one of the things I mentioned earlier is I'm able to work 4 different jobs. I'm able to work 4 different jobs because I can work 3 days to 4 days a week doing 12-hour shifts, 13-hour shifts, doing my normal basic, job. And so I have flexibility. I have ability to, be able to, if I wanted to hang out with my friends, if I wanted to go on vacation. I know that there's some nurses and some PAs and some other different types of providers who are able to work 7 days in a row and then travel for 7 days, and obviously you can't travel a lot now. Did you get your nursing degree while in college or did you get it after? So I actually got it after. So my original degree that I was working on was my biology degree. And then I also went to nursing school and I became a nurse practitioner. Any studying tips? For me, it was a lot of memorization and understanding the why behind everything we're doing, especially when it comes to, understanding medicine. So don't, when you're trying to study things like, oh, well, how do you manage someone in DKA? You have to understand the basic, foundations of how you metabolize glucose and all of these different things in order to do that. How do you balance your 4 different jobs? It's a lot of planning. Today, it's actually really funny. I was telling Josh that I think it was the first time in a long time that I caught myself because I looked at my calendar yesterday and I was like, oh, I have 4 different things going on. So I actually have 4 screens happening right now. And there's orientation for Hofstra and all this other stuff, but that's okay. Have you ever faced any notable difference being a male nurse in a female-dominated field? I can't say I have. I think that, the way I see it is it's an interdisciplinary team and we work together. Do you think nursing would be a good major for medical school? Learn a lot from the clinical side. I don't think most of the people that I know who have gone from nursing to become physicians, it's a decision where they feel like, they want to go ahead and advance their practice. I don't think a lot of people use it as oh, it's a stepping stone to go to medical school, because it's not, right? It's 2 very different fields and it's working together with an interdisciplinary team. I think one of the things that's really great, whether you choose to be a doctor, a nurse practitioner, or a PA, is to realize that every single field has its own specialties, has its own caveats. So an example, one of the things that's great about nursing is because before you go and advance your practice, before I actually go and become a nurse practitioner, I've had to work as a nurse. And so a lot of those bedside clinical assessment skills I've had, but that also comes with a lot of problems too. I've also worked and, I've taught on a graduate level and an undergraduate level that I can tell you that, sometimes you bring a lot of baggage too. You're like, oh, I don't need to learn that. I already know that. And I think that that's, those are some of the challenges. What has been the oldest nursing NP student you had, Chris? If there's older folks, of course, and that's the same. I've had older NP students. I've had older physicians who are residents. I think that, there is definitely, you can always, the sky is the limit. You can go back to school at any age, and age is never an issue. Do you think that nursing would be a good major? We talked about that. How do you balance work and life? You balance work and life, I think you have to, in medicine, you have to be able to separate yourself and have yourself have wellness. And I think specifically in the pandemic, we realized that a lot. For me, one of the most challenging things during the pandemic was that portion for me of my social life. I value my friends. They're my family, and I value spending time with them. And I see a lot of, really disheartening stories that I don't normally tell other people because they're just too sad, or they're just too, whatever. And how I cope with that is being able to spend time with my friends and kind of refresh my cup. And that was really challenging because during the pandemic, you're not really able to go out and do that. And so you learn how to, do other things to take care of yourself and find ways that you can do that. 4 jobs in the field of medicine. Yeah, they all are kind of related. Like I said, I teach on a graduate level, I teach on an undergraduate level, and I do critical care transport other than doing that. Finishing up your EMT program, that's really cool. Do you have any recommendations regarding employment? I would say for the EMTs, take what you can get. I think that that's one of the things, EMTs, I think are, kind of basis when you become an EMT basic, or, they used to be called basic. Now I think it's just EMT. It was funny when I was telling my story or putting this together. I remember back in the day in New York State, I was an EMTD, which stood for EMT with defibrillation. And like back then, only certain of us could do defibrillation. And then I became a critical care technician and all this other stuff. But I would say take what you can get, learn, and utilize that to learn. You can work in the hospital, you can work out of the hospital. So that's something also that a lot of EMTs don't know. You don't have to work on the ambulance. You can utilize that to be like an ED tech to gain some experience and try to understand. A lot of emergency departments have transitioned to utilize that EMT because it helps us with that assessment piece, right? So you have that assessment and understanding of what's going on. What are the physical stressors and the differences on being an NP or a nurse? So as an NP, you're a primary provider. And I don't really like to use the word provider because I think nurses provide as well. But you are responsible of, making orders and decisions and things like that. Nurses make a lot of autonomous decisions as well. But an example would be that, as a nurse, you might advocate for your patient for morphine or, whatever. And as a nurse practitioner, you're the person writing for it. So I think that that's, there's a lot of legal aspects involved in that. You're an independent practitioner and you work on a different level. Any insight on becoming a CNA? Yeah, so a certified nursing assistant, I think that's a great way to kind of start if you're trying to say, oh, well, what do I want to do? And a lot of CNAs I know maybe go into nursing, or maybe they go into becoming a PA, or it's all about experience, right? So much of what you learn in school is only what you learn textbook wise, but so much of what you do is based on experience. No textbook is going to teach you how to talk to a patient and give them bad news. No textbook is going to teach you, how to go and, understand and be able to read and assess a patient and know that, maybe they don't like it. And I can tell you plenty of providers who I've worked with who are very textbook, and, there's that humanistic aspect. So any chance you can get in to be able to do that and understand the patient as a human is really important. I'm an AGACMP student. Oh, that's awesome. You sounds exactly what I love to be doing. Thanks for. Do you have an ultrasound book or go-to pocket guide you would recommend for new grad NP? I would say anything that you know. There's lots of different things. There's apps out there. There's one app I think called Resus.us. Again, I'm not sponsoring it, but you know, and that's free. And so that's the beauty about ultrasound is you can really learn it. I know a lot of people who are experts in ultrasound and they learned it from watching YouTube videos. What would you do different in your medical path? I would say if I were to go ahead and change anything, when I reflect on it and I put together my story, I always think that, you know, if I were to change anything, maybe I would have been a little bit more of someone who believed in myself, because it took a lot of coaching for people to kind of help me get where I am. And if I was someone who's like, no, I'm going to be a nurse educator, no, I'm going to be a nurse practitioner, I may go and, you know, advance that. And that's basically. Any other questions?
I think we're right around 10 o'clock. You finished perfect timing right there. Thank you so much for joining us today.
Of course. Thank you guys. I wish you guys the best of luck. Like I said, always feel